Thanks to Dr. Manisha, Dr. Jobin. Thank you to all colleagues here. I think there are quite a few also colleagues attending and also all students. Thank you very much and a very good evening to all of you. We have about an hour to talk about something that I think all issues that are being covered in this lecture series are really complex issues, and I think speakers are trying their best to bring you research information as well as perspective, and so I'm going to try and do similar sort of a feat. I have a PPT. Before I go behind the screen, I just thought I will sort of say hi and say that, so I will try and keep about 15 minutes in the end for Q&A, but feel free to keep sending questions on the chat. I will, I think, look at it only in the end. If you must stop me because there's something I've said that makes no sense and you would like clarification, then that's fine too. Then you can just unmute yourself and speak. Thank you very much for that. Okay, so let's get started. Hi, Reena. Thanks for switching on your video. It's nicer to not have to speak to only black boxes and or pictures. Okay. So let me start my screen share. And I hope you're able to see this.
Yeah, it's visible.
Slideshow. Right. Okay. All right. So the topic I've been asked to speak about is gender and mental health. Just to say a few words before I go into specifics of my talk. One is that when we think about gender and mental health, typically most of us would think that this talk is going to be about men and women and their mental health. So which is how we think about gender. Of course, we understand now increasingly as there is more and more visibility to what I'm referring to here as gender minorities. That is, people who may not fit into the box of man and woman or who may fit into the wrong boxes. For example, there would be people who are born and assigned gender female at birth who might grow up and say they feel like a man, and these are trans men. And there would be people who are born assigned gender male at birth who grow up saying that they feel like women, so they are trans women. So now we increasingly understand that there are also transgender persons apart from men and women. But I am in this talk going to focus on what in the mental health sciences have we understood by gender and mental health. Yeah. So generally what comes to mind is men, women and mental health, but often traditionally within the mental health sciences, gender and mental health has been equated to women and mental health. So when we talk about gender and mental health, actually what is being spoken about traditionally within psychology, within several side disciplines, is actually women and mental health. And again, traditionally, when we mean women's mental health, we often mean reproductive health and mental health. Okay, so this has been the sort of trend within research in mental health sciences, and so that's what is reflected also in our curriculum practice, etc. So this is just to highlight that often when we think of gender and mental health, what is being spoken about is women and mental health and also reproductive health and mental health, right? Now, the other thing I want to also suggest is that when we think about gender and mental health, there are two ways of approaching this, which is what I'm going to try and do in this very short 40-45 minute session with you all. One is there are epidemiological studies that talk about gender and mental health, where basically when they say gender, what they mean is they are using gender as a demographic variable. Okay, so you have that sheet, face sheet hota hai research mein, where you have a demographic background variables, where one of the first questions is name, followed by sex or gender, right? So gender and mental health can be done like that, where you treat gender as a demographic variable, which is basically then sex difference research. So you will have standard sex difference research, which tells you clinical research, for example, what kinds of disorders are more common in women, what are more common in men, so prevalence of certain disorders, onset, course, outcome of illnesses, and talk about this as sex segregated data, so sex difference data. How does it affect men differently? How does it affect women differently, right? That's one way in which gender and mental health research has happened within mental health sciences, and that's something I will sort of give you a very brief sense about. I think I can of course share a lot of reading material, and there are several review papers. Review papers means basically these guys have done the literature review and they put together all the studies that exist in the area of gender and mental health. So I'll just point you to some of that. I can share those with you, which basically tell you about sex differences. That say, for example, depression is twice prevalent in women as compared to men. So that's the gender as demographic variable kind of data. The other thing I want to talk about today, which is a little more complex, and I think I can only do an introduction or a tip of the iceberg of that right now, which is to talk about or think about gender as an analytic category. Okay, what that means is it is not just looking at sex difference in prevalence of, say, schizophrenia or depression, but it is also asking more questions about sort of analyzing this. So, for example, a question like, why do these sex differences exist? Is this a function of biology? Is this a function of society? Is this a function of sex role socializing? Is this a function of resources, access to treatments, etc., etc., right? So gender as analytic category is a little more complicated than gender as a demographic variable. Okay, and what I'm going to try and do in my session is address both these issues. I'll start with the sex difference or gender as demographic category. So I think many of us may be familiar with this, but I'm just going to tell you a little bit about data. Yeah. So, for example, there's a WHO report on gender and mental health. Again, it's called gender and mental health, but it's talking about women and mental health. So the report says that depressive disorders account for 41.9% of disability due to neuropsychiatric disorders among women compared to 29.3% among men. We also know that lifetime risk of anxiety disorders, for example, generalized anxiety disorder, is 2 to 3 times higher in women as compared to men. In India, community-based studies as well as clinical studies, right? So studies that were done in general communities as well as studies that were done in patient population tell us that women on an average are 2 to 3 times at a higher risk to be affected by common mental disorders, right? Leading mental health problems of the elderly are depression, organic brain syndromes, and dementias. Majority among these are women. Yeah, so these are some prevalence-related data that are telling you that women are more at risk for some things as compared to men, right? So this is one kind of gender as demographic variable. Then you have gender difference in suicide research, yeah, and there's a lot of it out there. I'm just going to summarize a few things. So, for example, global trends on suicide research tell us that women attempt suicide more and men complete suicide more, right? In India, we have it a bit reversed, where we have women who outnumber men in deaths by suicide. And we know that often suicide-related deaths are underreported, but what reporting is there from the NCRB data of the Government of India, we know that women outnumber men in deaths by suicide, although the gap between them is not very large. Yeah. So other studies have suggested that marriage and young age at marriage is linked for women with suicide attempts and self-harm. Similarly, suicide rate by age for both men and women tends to be highest in the age group of 18 to 29, but it is higher for women in the age group of 10 to 17. Okay, so this is about gender differences in suicide research. Gender differences in severe mental disorders. There are considered to be no marked differences when it comes to prevalence of severe mental disorders between men and women. And generally in population, this is about 2% is likely to be the prevalence. Cross-cultural studies have suggested that female gender is associated with better course and better outcome of schizophrenia in developing countries. Women generally have a later age of onset for schizophrenia as compared to men. In terms of the clinical features of disorders itself, women have a more frequent, are more likely to have episodes of depression, and they are likely to be more rapid cycling and also affected by seasonal patterns of mood disturbances among men and women with bipolar disorder. This is more likely to happen to women, right? Then you have substance use disorder data, which is gender-wise segregated. We know that historically, globally speaking, most SUD data was collected on men. So you had only male participants in these research studies, and that's changing quite a bit in the last about 25 to 30 years. The gender gap in prevalence of substance use disorders is rapidly narrowing, particularly in the global north. Yeah, so a lot of data from the US suggests that this gap is rapidly narrowing, and women are suffering from SUDs as much as men, if not more. Access to substances, of course, is a social and cultural factor. So we do understand that in the Indian context, some studies that have been done in rural areas as well as cities like Bombay, etc., do indicate that access to tobacco and tobacco chewing is culturally more acceptable for women, especially tobacco as tooth, like a tooth cleaner powder, that kind of thing, is something that is more common. Illicit drug use is significantly higher among men compared to women. This is not Indian data. Psychiatric disorders that co-occur with substance use disorders tend to be, again, anxiety, depression, PTSD, suicide is more common in women, and more externalizing types of disorders such as conduct disorder, antisocial personality disorder are seen more commonly in men, right? Just bear with me with some of this sex difference data. This is data I understand, and it's sort of papers that you can read up. The reason I'm focusing on some of this is to tell you that traditionally within mental health sciences, this is how we have understood gender and mental health. We've understood gender and mental health as what are men more prone to, what are women more prone to, right? So similarly, substance use data suggests that women before the onset of substance use disorder have experienced traumatic event, or are likely to have PTSD before the onset of substance use disorder. Women tend to get more into trouble in sort of with substance use, more in the context of employment, social, familial context, as well as medical and psychiatric functioning. Men tend to get into more problems legally, around substance use disorder. Those are some of the studies that are suggesting this. Now let me move to gender as an analytic category. Yeah, sorry, I just realized that. So what I was talking up to this point, was basically about gender considered to be a socio-demographic variable, and sort of what are some of the problems that are more commonly seen in men as compared to women, and what are the clinical features, what is likely to be the course outcome, that kind of thing. And there is actually ample of data of this kind on CMD, SMD, of course, common mental disorders, severe mental disorders. You have that around suicide, you have that around treatment seeking, you have that around treatment outcomes, utilization of treatment, etc. But this is just to give you a sense that there is, this is one way of looking at gender and mental health. Now, what I'm asking us to do is to think about, if we were to try and ask questions about, let's analyze this data. Why is this like this? And there'll be sort of multiple ways of doing this, and I'm just going to tell you a few ideas within gender as analytic category. Okay, so again, so in psychological theories, there has been three sort of very important ideas that have been spoken about in the area of gender and mental health. Actually, let's make it four. So one is research by somebody called Sandra Bem, who talks about something called as androgyny. Yeah, and so androgyny research by Bem way back in the 80s is basically to try and understand that what are characteristics of men and women, and most human beings tend to be also masculine and feminine. Yeah. So she's trying to say the psychological characteristics of masculinity and femininity, and she's trying to suggest androgyny as sort of a notion of adult, healthy, mature person, actually having both masculine and feminine characteristics. That's Sandra Pem. But the three other things I want to focus on is Harry Mustin and others have raised this question of what is called as alpha bias and beta bias in psychological theory. Now, what is alpha bias? Alpha bias is to say that there are some kinds of psychological theories, formulations, etc., which tend to exaggerate differences between men and women. And I'm currently staying in the realm of men and women. We can talk about other genders later. So alpha bias, for example, when you have the idea that Freud talks about the idea of penis envy. Yeah, where he's basically going with this assumption of one kind, so it's basically what is happening here is that you are looking at differences between men and women. One is you're saying that these are essential biological differences, and the other thing you're saying is that that there is something about men that is distinctly different from women. Yeah, so you're sort of saying that these are two it's not possible to mix these two, and you're sort of exaggerating the differences between men and women. So you have some psychological theories that tend to do that. The other kind of theories that you have, so for example, a whole lot of research in the initial psychological research which says women are mothers and are nurturers, and therefore they should be doing certain kinds of things, or they are best suited for certain kinds of roles and jobs. Yeah. Now that's an alpha bias, right? Men are best suited for certain kinds of jobs, right? So which is basically exaggerating and biologizing differences between men and women. Then you have something called as beta bias. Beta bias does the exact opposite, where it says basically that there is no difference. We're all human beings. Yeah, there is no real difference between men and women, and in doing so, what it is doing is it is ignoring socialization and role of socialization in men's and women's development. Yeah, a very classic example of the beta bias is, you may have heard of Kohlberg's theory of moral development. Yeah, and it's a very common thing in beta bias. What is happening is that you do studies with men and you apply those to everyone. Yeah, so you say that what is the difference? It doesn't matter. So Kohlberg, for example, talked about moral development, and he based this mostly on a male sample. And then you later have somebody called Carol Gilligan, who says that women grow up very differently compared to men, and women's notions of right and wrong are very different from men because of how they are brought up. Yeah, and because of femininity being valued and value associated with nurturance, etc., etc. So women develop morally very differently, and women's notions of justice and right and wrong can be quite different from men's notions. And so she challenged Kohlberg's theory of moral development, saying that this is actually very, very the third bias, which is androcentric. Okay, this is done from a very masculinist understanding of of what is normative or what is development. Yeah, so that's the third one, which is androcentrism. So you have alpha bias, which basically exaggerates difference between men and women and says this is all biological. You have beta bias, which says there is no difference. Androcentrism is basically looking at the world or looking at psychological phenomena or psychosocial phenomena from a male perspective. Okay, and there's an interesting study done by Broberman and Broberman. What they did was they did a study where they got mental health experts, 79 psychologists, social workers, and counselors, and they asked them to think about a healthy, mature, mentally healthy person. And think about a healthy, mature, mentally healthy woman and a mature, mentally healthy man. Okay, and they basically asked them to list who's a mentally healthy man, who's a mentally healthy woman, and who's a mentally healthy person. They asked them to do it along certain characteristics. And what they found was that the list for a mentally healthy man matched the list for a mentally healthy person, whereas the list for mentally healthy woman had characteristics, even for a healthy, mature woman, which are quite different from those meant for a mentally healthy person. Yeah. So, for instance, competence cluster, independent thinking. So somebody who's competent, somebody who's independent, somebody who's able to take decisions on their own, somebody who's rational, were attributes that were considered to be mentally healthy for a man and mentally healthy for a person. But whereas being more emotional in their decisions, being interdependent, being nurturing, were notions, or those clusters were considered to be traits for mentally healthy women. Yeah. So what they concluded was saying that in psychological research, the notion of mental health itself is androcentric. Yeah. Where by definition, even when you're thinking of a mentally healthy person, we're actually saying that women are somewhere less than mentally healthy. Yeah, so that's androcentrism. So this is what I'm saying is gender as an analytic lens has been used. So these are three biases that we might want to read about in psychological theory. Couple of other points I have put down here is, for example, if you were to use social determinants frame in mental health, social determinants frame is to say that mental health is affected by various social positions that we occupy. Yeah. So, for example, if we use the social determinants frame and bring gender as one of the social determinants, then we have studies that are done in low and middle income countries that tell us that being of a female gender and facing gender-based violence and being also poor and having low education puts you more at risk for common mental disorders. Okay. This is basically a gender as analytical lens and an intersectional lens. Okay, where what you're doing is you're saying that female sex, poverty, illiteracy, and likelihood of facing violence puts this person more at risk for mental health problems. Yeah. So this is what is happening is it's an intersectional and a gender analytic lens to understand the sex difference data, which I showed you earlier about, why do women have more depression compared to men? Yeah. So this is just to say that gender as analytical lens, how does that appear? Another very interesting place in which gender as analytical lens gives us some interesting insights is on what I said in the beginning, that when we talk about gender and mental health, historically, we have basically talked about women's mental health, and we basically in women's mental health talked about reproductive health and mental health, right? Now, why has this bias been there earlier? Because we mostly understood women's mental health as somewhere lying within their reproductive systems. So we thought that it is hormones and it is reproductive plumbing that women have, and then the reproductive events that they go through, namely menstruation, menopause, pregnancy, and childbirth. Yeah, and all of this linked with what it does to their bodies and hormones, that causes difficulties with their mental health. So this has been the old way of understanding reproductive health and mental health, right? Now, when you shift gears from hormones to social determinants and understand the same research, reproductive health and mental health, what happens? One of the things that happens, and I'll show you a little bit about that kind of research, but one of the things that is raised, or one of the questions that is raised is, what about men's reproductive health? And what about men's reproductive health and mental health? If it's not just hormone driven, yeah, men also undergo reproductive events. They also become fathers. They also face issues like infertility and the pressures that are associated with that. They also face the trauma of stillbirth. If the child was born, so you're anticipating childbirth and, child is born, so it's a stillbirth. So the minute you shift from this hormonal understanding and the biological understanding of reproductive health and mental health, you will then start asking questions about, okay, so what happens to men's mental health as well? Yeah. So that's to say that when you bring gender as an analytical lens, what you're doing is actually you're doing something methodologically in the way you're posing questions about gender and mental health. Right? And I'll give you some more examples of that as we go along. The other thing I wanted to point to is the whole lot of research on violence against women and mental health, yeah, which has been done from gender as an analytic lens. That why is it that women suffer certain kinds of violence more? So, for example, domestic violence is something that women disproportionately face much more. Certain other kinds of violence that communities face. For example, we are seeing what's happening in Afghanistan right now. Yeah, we know that everybody is facing that violence, or everybody is facing the threat of that violence. It's not a gender-specific phenomenon in the sense, not just applicable to women. But women, Afghan women, are likely to face a different kind of violence or a different range of things that are likely to happen as compared to Afghan men will also face it, but it will be of a different kind, right? So that's about bringing in a gender lens on violence against women and mental health research. And the final thing, if I have time, I'll talk a little bit about it. But again, another old story on gender as analytical lens and mental health research has been this idea that women suffer more from internalizing disorders. So you have depression, anxiety, etc. Men suffer more from externalizing disorders. So you have substance use disorders, antisocial personality, conduct disorders, etc. And what does these gendered expectations? So if you think about it, clinicians also have these gendered expectations. That when a man is upset, he's likely to, how is he likely to express his distress? Yeah. There are social prescriptions on how men should get upset and how women should get upset. Yeah? Similarly, so there is research that suggests that clinicians also expect men to be upset in a particular way and women to be upset in a particular way, leading sometimes to biases in diagnosis. Okay, and so there is research, especially upcoming research on this very controversial personality disorder category called borderline personality disorder, which is seen as a predominantly female malady. Yeah, and now research suggests actually that it is a clinician bias. Often we are not exploring in young men the kinds of characteristics that that form borderline personality, and actually a lot of undiagnosed BPD men maybe around us. Yeah, so that's just something that I may not get much time to go into great deal of details, but just want to check what's the time. Okay, it's almost 7. Okay, so this is to say what happens to reproductive health and mental health research when we also bring in the gender as an analytic lens. Now, of course, we know about prevalence stuff, postpartum blues, how common it is. I've just sort of thought of bringing in 2 studies. One is Vikram Patel and another person called Chandran, this I think done in Tamil Nadu, who basically told us about postpartum depression. Prevalence 23% and 16%, and persisted for 6 months in 11 to 14% of women. Now, when they look at the factors behind this, what they're saying is these factors are associated risk factors are poor marital relationship, intimate partner violence, unhappiness about the gender of the child. So expecting a male child and a female child being born, poverty, and having already a living female child. Yeah? Similarly, systematic reviews on non-psychotic common perinatal disorders in low and middle income countries again tell us something about data around women. I'm just going to move to, this is again prevalence data, but I'll just move to a few more what I was saying about gender as analytic lens. So when we do have gender as an analytic lens, one thing we are doing, like we can see here, is that we are moving beyond biology and hormones. And we are saying that biology, of course, is playing a role. We're not denying it, but we are saying that there are several of these other things, including, male preference in children, pregnancy, younger age of pregnancy, and what these things may mean. Some research on, which is not India-based data, but I haven't put it, it's a Lancet study. Which basically tells you that women who suffer from severe mental illnesses have lowered fertility rates because of higher rates of abortion among women with psychiatric disorders. Role of prolactin raising antipsychotic drugs. Here is your biology that makes conception difficult, forming and sustaining relationships. Women with severe mental disorders who get pregnant, their pregnancies are more likely to be unplanned and unwanted as compared to in the general population. Pregnancy-related relapse of mental illnesses. Again, there is role of drug default once the pregnancy is known, hormonal changes, sleep deprivation, taking on the role of mothers, caregiving, all of that. So a range of psychosocial factors. So all of this can complicate the relationship between reproductive health and women's mental health, particularly women who already have a mental illness pre-existing, right? This I already said. What about men's reproductive health? If we move from gender as biology to gender as socially constructed, then all of this becomes very important. One thing I must sort of suggest also here is that if you look at men and mental health, sexuality and sexual performance related mental health research is quite very much there. Yeah, so these are significant themes in men's mental health discourse: sexual drive, sexual performance, etc. So it's almost like in sexuality related research, you have women who are underrepresented and you have men who are overrepresented. And in reproductive health research, you have women who are overrepresented and men who are underrepresented. So this is also something which is sort of, when you look at gender as analytic category, these are some of the questions you ask. Now this is research on women violence and mental health. So again, some demographic data. So we know the lifetime prevalence rate of violence against women is this much. There's an interesting paper which looks at sexual victimization among women who have severe mental disorders. We also have data from India, actually, Prabha Chandra's work on women who have been admitted into mental hospitals and the kind of sexual violence that they experience. Their husbands, but also other authority figures in the community. There is data again from Sangat, somebody called Neerja Chaudhary, who's worked on spousal violence as an important factor in suicide in women. Yeah. So yeah, I just wanted to sort of draw all of this data to say that there is women and women's mental health that is affected or disproportionately affected, which is very closely related to women's position in society. Yeah, and the fact that women face more violence, more these kinds of sort of life events, negative life events. Another interesting turn in this women and violence data is a study done, actually is published in IJP, Indian Journal of Psychiatry, which looks at sexual and non-sexual boundary violation in doctor-patient relationship in India. Yeah, and between male doctors and female patients. And this is a study done with psychiatrists and psychologists in Karnataka. And what the respondents have said is that they've heard of allegations of sexual boundary violation that were investigated, and some talked about violations that were not investigated. It's an interesting study, also has some qualitative data which you may want to look at. So that's the women in violence sort of data. Then we have service utilization. So we do know that women tend to more likely to go to non-specialist care, more likely to go to traditional healing spaces. More specialist care is something that more number of men are likely to access that. This is old data about availability of beds, and something I found in a 2015 article about sort of ratio of male to female psychiatric beds. And it's fairly stark. I'm not sure if this is so now. This is really old. As I said, it's 99 data. It's important to probably look at what some of this data would look like today. So yeah, that's about gender and service utilization outcomes. Again, studies done on this favorable outcome vis-a-vis severe mental illness have also sort of got us to think about social consequences of mental illness and severe mental illness among women. That women are much more likely to be abandoned by marital families. We do know there is actually some data on from Pune Family Court that suggests that the clause of unsoundness of mind gets used much more against women to cite reasons for divorce or to cite annulment of marriage. Yeah. So abandonment of women due to mental illness, homelessness, vulnerability to sexual abuse, exposure to HIV, making it difficult to rehabilitate women. We all know that long-standing patients, chronic patients, quite a few women in mental hospitals as well. So mental hospitals are often getting used as these dumping grounds where women with severe mental illnesses are present. So just a minute. Okay, I'm just aware of the time. So before I go to my last slide, yeah. So I just wanted to make this sort of underline this point once again, that one way to enter this conversation on gender and mental health is to think about sex differences in rate, prevalence, onset, course, outcome, and service utilization of men and women, and for which, like I said, there are some review papers that suggest certain kinds of disorders being more common in men, certain kinds of disorders being more common in women. That's one way to do it. The other is what I'm just suggesting here as well, that in addition to doing the sex difference research, looking at some of these from a psychosocial perspective, looking at how men are brought up and raised, how women are brought up and raised, what is access in terms of resources, in terms of mobility, and in terms of also social expectations. So you are allowed to be upset in this way. So there are prescriptions, right, about if you are losing your mind, how do you lose your mind, right? So there are social prescriptions on all of that, and that's something that also gets reflected in some of our research. So that's just something I wanted to say before I go to my last slide, which is on trans persons and mental health. This is just to say that I think many of us may be aware that that we now in India have what is called as a Transgender Persons Protection of Rights Act 2019, passed by the Government of India in December 2019. And why I'm raising this is that because there is a law now, I mean, trans people have been around forever. And particularly in our region, I think Hijras, Brahmanis, Shiva Shakti, Jogappa, Jogtas, which are all culturally prevalent categories where people who did not fit into the world of men and women, these people have existed sort of historically in our region. Right? But today, the reason I'm pointing out to some of these things, particularly for mental health professionals and budding mental health professionals, is that one is there is a whole discourse now on trans mental health that is emerging in India as well. And we are increasingly talking about higher rates of depression, alcohol use, victimization, violence against trans women, and how. So this is more recent data by somebody called Venkatesh Chakrabarty from Chennai. There are quite a few studies now that are emerging that are telling us how trans people are more at risk for mental health problems. Gender minority stress model. Somebody called Ilan Meyer from University of Columbia has talked about prejudice and discrimination as psychosocial stressors. And has sort of shown us the links between gender minority stress and mental health outcomes. So that's something we may want to familiarize ourselves with. And the third thing I definitely want to highlight is psychiatric social workers, like other mental health professionals, have a big role to play in what are called as gender affirmative therapies. That is basically transgender people who are binary transgender people. So people who say that they are born in the wrong body. So these could be trans women who have male bodies and who are coming into psychiatric consults where they want to undergo medical transition, they want to undergo hormonal therapies, want to undergo surgical interventions and so on, for which, in order to do that, a mental health professional's letter, what is called as letter of support, it used to be called a certificate. Now it's called a letter of support, where mental health professionals have to do a full assessment and say whether this transgender person, A, are they suffering from any other mental illness? So is it that I think I'm a trans person because actually I'm suffering from a delusion? Yeah, or I might be suffering from a severe mental disorder. Yeah. So the job of mental health professionals is to find out, is there any psychiatric comorbidity here? Is the transness result of that psychiatric comorbidity? Second is, if the person does not have a psychiatric illness and they are a transgender person, then to see if they understand what medical transitioning means, do they have the social support for it? So do a full psychosocial assessment before any other medical interventions can happen. And the WPATH, which is the World Professional Association of Transgender Health, has developed what are called as standards of care guidelines in 2011, which is what is being used world over today. I know that in NIMHANS and some of these places, these guidelines are being used. It's mostly psychiatrists right now who are providing the letters of support, who are doing the assessment. But if a trans person wants to undergo medical transition, a mental health professional's letter is mandatory before they undergo any further interventions for hormone surgery, etc. Right? So for psychiatric social workers as well, we may want to pay attention to some of this and look at how to do these assessments and how to go ahead and do letters of support for trans people, and also of course how to understand minority stress and do therapeutic work, support work with trans people. Just in the last 6 months or so, I have been seeking students, actually mostly students from clinical psychology, who have gotten in touch to try and understand, they have a trans client who the psychiatrist has referred to them for psychometric testing to say whether this is gender dysphoria. Gender dysphoria is a category in the DSM-5. So is this gender dysphoria? Is this something else? Should they be helped and supported in medical transition? And that's something that is likely to come our way as well as PSWs, and so that's something we may want to sort of look at in the Indian context. Okay, so having said that, I'm going to stop here.